Welcome back to the Ankle Man podcast. Today we're going to talk about something that we all see. David is here with me again today, and we're going to talk about Lisfranc. We're just going to go through some cases, talking about principles, philosophies, and some unique things that I've done for Lisfranc injuries. And we know there's no right answer, but it's very common, and it's something that we have to deal with all the time to get them back to play. So the first case is, I think, the most unusual case that I had. So this is a Northwestern athlete. This was years ago, but he came in with this. It was the first play of the game or first game of the season, something like that. And had a homolateral Lisfranc injury, purely ligamentous with some fractures of cuneiform. So David, you're the guinea pig, right? It's easy. I already know what I did, but yeah. High-level athlete, very young. First question is, you see this in the ER. Are you taking it that night? Are you just doing sedation and popping it? Like, what are you doing for the acute aspect? Because that skin's at risk.
I mean, you could like close reduce it with like a Chinese finger trap, close reduction. CT first, obviously, that's the given, and then try to stabilize the soft tissue either with a small X fix or something or pinning. I'd probably take it that night, to be honest, but that's me.
I think that's key, dude. I think if you're going to see this, try to reduce it in the ER if you can. If not, it's got to go to the OR and reduce it. And then I actually now become a big fan of just transarticular pins. I think it's super easy.
Right.
And I think for a lot of docs that may not, know what to do with this, your partners, you can always fire a couple pins across and then let somebody else sort it out,
Right. I agree.
But leaving that skin is a disaster. I've heard about the anterior tib being entrapped. I've never seen it. I don't know if you have.
Never. Nah, not in my experience, but you probably do a lot more trauma than I do. So
I used to. Now I just redo a lot of stuff. I'm going tomorrow to another hospital go redo something. But I think when you get in trouble, if it's not reducing closed, just make a small incision, take a fear, and just pop stuff out of the way. That can always help. But long story short, you can't leave this because if that skin necrosis that medial side, it's obviously a nightmare.
For sure.
So this gets pinned. It gets sent to you, right? Now it's grossly unstable. This is an intraop after reduction.
Right.
So I'll give you this much. So there's your intraoperative video. So everybody in the audience can see it's unstable dorsolateral, but it was reduced and pinned and then came to me. So what do you do for this young athlete, 1 through 5? That quote unquote soft tissue, not bony Lisfranc. Are you fusing 1, 2, and 3 right off the bat? Pinning 4 and 5, or IFing this thing, sprinkling holy water on it? Like, what are you doing here, man?
So it's always like RIF versus like fusing. I am very low threshold for fusing in the medial column for myself. And simply because I feel they ultimately end up having to need a fusion later. I'm also in a private practice setting, so patients are looking for one and done. I think the medial column is stable enough. It should be able to tolerate a fusion just fine. And most of my patients do well afterwards. If I do a RIF, ultimately they come back. They just come back and I have to do it again. So, but I know it's an athlete, so that's the kind of,
That's the trick here, right?
Yeah.
So are you a Lapiducer or an MIS bunioner? So I think that's part of the philosophy a little bit for this.
Yeah.
Like if you do a lot of Lapidus, then I don't know why you wouldn't ever not fuse this because you clearly don't think the first TMT has any value.
Right. So I used to be a Lapiducer until MIS came along. And so I became an MISer. And I can't even remember the last time I did a Lapidus.
About the first TMT threw it went out the door, huh?
Yeah.
It was funny. I was
One and done.
Same, dude. I used to think the first TMT, I did a lot of Lapidus. I was never fully satisfied with my outcomes when I started talking to them a lot. In short, I think for like a laborer, a lineman that needs stability, I agree with you. 1, 2, 3 TMT fusion, workers' comp, where they just need stability, I think that's great. Right. I do think for an athlete, the first TMT has some value. I think. Now there's a nice military study that shows with straight running, fusion did better than RIF.
Right.
And I think you're right, they come back. But I think when I look at the midfoot, and I don't know if you believe this or not, the middle column, second and third, are really just stabilizing parts, right? They're
Sure.
forced transference front to back. The lateral column is obviously for ground accommodation, but I do think the first, it moves about a centimeter, has some role as you pivot around 2 and 3 for cutting.
Sure. Yeah.
Like the inline running probably don't matter, right? But I think
Yeah.
for cutting it does. So that being said, you'd fuse 1, 2, and 3, 4 and 5. Are you pinning them a lot, or are you just letting them follow 1, 2, and
Yeah,
3?
I pin them a lot actually. I do a
You
lot
do.
of pinning for 4 and 5 to the keyboard. Yeah, I do it and then I just pull them later. They seem to do well with that. I haven't had too many comebacks or issues with it. Most of the stuff that comes back to me for Lisfrancs, if I fuse them, is the hardware. They don't like the hardware in there. Doesn't matter if I put a screw, plate, whatever. They don't like that.
Don't like it all.
They
I
just
know
come back for it and they want it out. So
they want it out.
yeah,
I think it's just prominent stuff, you know?
yeah.
So I'm not a pinner of the lateral column much anymore. I think if
Okay.
it's reduced, I just leave it.
Yeah.
But, you know, it has to be reduced. So this is a case where I did a 2-3 fusion, but there's nothing on the first TMT, as you can see.
You didn't
So
even
this
pin
is
it,
what
huh?
what's that, David?
You didn't even pin it, or you just left
No,
it.
I'll show you. So it's
Hmm,
not like I quit. So I
sure.
did plates, and I do like the retrograde Lisfranc screw, which we'll talk about in a sec, which way you go for your Lisfranc screw. But
I
I
go
had
on.
this in
Go on.
my little world an epiphany. I was like, well, if I fix the middle column rigidly and fuse it, where can the first TMT actually go? It can't abduct. It's got nowhere to go.
I think it's just
So
dorsal, right? Like
dorsal. So I was
yeah.
like, well, why do I have to drop a huge plate or fuse it just for that? So
Mm,
I said, well, I got this internal brace, right? I said, I've used it all sorts of places. So if you look at that carefully, David, you can see I put the internal brace plantar medial, and
okay.
it locks it, and I never have to come back. And I've done this maybe 5 to 6 times in these 1 through 5 injuries,
Right.
and they've done phenomenally well. Like the athletes, I'll show you how this person did. I do this race to back the blue. Some of you may who are watching may see that shirt that I wear, because it's a charity thing that I do.
Sure.
And the police officer, SWAT officer that I got back had a 1 through 5 as well. And I did the same thing to him, and he's back full duty, no pain, 1 surgery. So I think sparing motion the first TMT may be beneficial. It's impossible to know. My series is small, but it is stable, because once you fuse the middle column, the medial column doesn't have anywhere to go.
Yeah, it can't go lateral. Only yeah, you're right. Dorsal, but if you have that internal brace,
It kind of locks it. So I
yeah.
don't, because I think on most of my takebacks and complaints when I did Lisfrancs with RIF were the first TMT.
Now, do
The
you go over
second,
the tibialis anterior or you go under?
just under it. You
Mm,
sneak, it's like a trapezoid,
yeah.
slightly plantar medial, then you aim kind of
Right.
distal in the metatarsal and proximal in the cuneiform. So
Mm,
you're aiming away from the joint so you don't get too close to it.
right.
And I just use 2, 3, 5 swivel locks, the small ones. So
Sure.
it's a low footprint.
Right.
So it kind of works. So there he is now at 9 months. You can see the fusion took lateral position, looks good. But the real proof is this. Like, this is the same patient at 9 months, cutting after a 1 through 5 Lisfranc, went back and played in the bowl game. I mean,
Right.
I'm not saying it's like, oh, this always works. Don't get me wrong. But I think when we look at Lisfrancs, it's not just 1 through 5 are the same,
Yeah.
or 4 and 5 are special. I think we look at each column individually. This is my thought. And each patient slightly different, right? What's their need? What are they willing to tolerate? And I don't like putting across the first TMT. I hate
Right.
that. But I think you do too. I think they just
Yeah.
hate it. And even when I would plate them, I take out the hardware after like 3 months. Still sucks. Still stiff and painful. Used to wait 4.5 months. They're still painful. They don't like it. I think you stiffen up that joint, you ruin the joint.
And then periarticular arthritis.
Yeah. So
That
now, like,
comes
this
later.
sucks.
Yeah.
So I think this is just a cool case. I've done this a few times. I'm not saying everyone should even try this, but something to think about when we look at Lisfranc injuries.
Right.
There's a different one. So 43-year-old male, told one quick screw would solve his problem. So I'm curious, what do you see here? Like, do you see this as a big deal? As a single retrograde Lisfranc screw? What would you do here?
So I kind of adopted Meyerson's technique where I do one Lisfranc screw and one for the intercuneiform, like that. And
So
that you
retrograde and then intercuneiform screw?
yeah. And that seems to work out really well. Very rarely I have to take those out. They kind of stay in and they do pretty good. So
So would you would fuse this or fix this one? Because it's 6 weeks out. I don't know if that's a big deal to you.
so I had to breathe that inner space a little bit and I would probably fuse it. Like I said, I told you very early, I have a low threshold for fusing for the midfoot. It's just the medial column, I just feel like it needs to be stable. So
it's hard to argue with that philosophy. Like if you treat a lot of Lisfrancs, you're just like, I want the safest way to treat these things. Not that fusion takes a little bit more time.
Yeah.
I think fusion is by far the right answer. So in this case, I did a fusion because it's 6 weeks out. The midfoot, in my opinion, as you see here, it's obviously abducted.
mm-hmm.
So I fused the second TMT, just like you said, right? Because what's the benefit of RIF here? I don't see any.
Right.
He's already 6 weeks out. You can roughen it up, but a fusion is always going to be reliable, and the second TMT has no value.
Right.
And then I did an IB for the first TMT again. Now that's my own unique weirdness. My question to you is, in this case, would you have fused the second? Would you have just fused the first TMT as well? Because you can see it's definitely unstable here.
I probably leave the first TMT alone, to be honest. Obviously, once you do your second TMT, then you stress it intraoperatively, see if there's any instability, and if there is, then you can do something about it. But most of the time, in these like little fleck kind of cases, I don't have to touch the first TMT. So
you exactly think what I'm thinking, man.
Yeah.
Once you lock that, so obviously I'm a little bit goofy, so I thought maybe, but you're right. I think it's only unstable sagittally. So the patient did pretty well. I don't know where the hell my final follow-ups are, and I always apologize for that. But I think this concept has value. Now the screw. How do you put your Lisfranc screw in, and does it matter?
I do it opposite the way you do. I don't know. I mean, I guess it doesn't matter in my case, but I just find it very easy to throw it from my direction, from the medial cuneiform. And then when you take them out, I guess when you take them out with your orientation, you just need one incision.
Usually.
Versus I need two.
So. I never take this stuff out though. So I'm what Chris Coetzee would call a closet fuser, right? Like I don't touch these. If I'm doing a second TMT or IF, I'll lock it and go and never look back. Yeah, I don't think it matters. Like, so here, you do an RIF, acute subtle injury like we just saw, did RIF second TMT. If you did an RIF, would you take out your midfoot hardware?
Oh, definitely not. I mean, the only thing that's holding it in place is that and potentially scar tissue.
That's what I think too, man. So I think if you're gonna, if you don't like fusing things, like some people in the audience, they may just like, look, I'm not taking the time, the effort. It's a pain in the ass. I don't want a non-union.
Right.
Then lock up the middle column with the second and third, whatever you need to do, retrograde, Lisfranc screw, antegrade, and then don't touch it. Because you're right, dude. It's scar tissue in the plate. So just never take it out because you don't need motion here. You just want stability. And I've been much happier with that than getting these late recurrences after I took out hardware when I was young.
I think you just have to prep the patient ahead of time that down the road there might likely and potentially might be another surgery to fuse it, and it's another 6 weeks and all that stuff. If it doesn't do well,
And I think that's fine. I will tell you though, when I'm leaving the middle column hardware in on a subtle injury, I've not really had to go back. If it's a horrible injury, different discussion. But ones that don't have sagittal instability, like the first case was sagittally disrupted, I think that demands a fusion.
Right.
I think it's more coronal and not sagittal, like this case, even though I did fuse it because it was later. I think you can not get away with. I think an RF is totally appropriate, but never touch it. Like just leave it alone.
Right.
This screw trajectory was described by Vinod Panchbavi, who's a buddy of mine out in Texas. And I think it's actually easier because cuneiform's so big. So it's an easy target.
Right.
Mechanically, it's stronger, but clinically, I don't think it makes a difference. It's just a choice. Because I have my incision there, I'm just
Nice
going
one.
right through what I see, so it's easy for me.
What
Here's
about
another one.
the
This is a
first
curious.
case coming up?
What's that? Oh yeah, the case coming up. I mean, you'll be looking right at it, and it's such an easy shot.
Yeah.
I do a cannulated drill and a solid screw. It's like dumb easy. Here's one. This one was told this is a foot sprain, and you and I both know this is commonly missed in the ER. And I tell my fellow and resident, there is no such thing as a foot sprain. That is not a diagnosis. And I refuse to believe there's such a thing. Now, there could be a grade 1 Lisfranc that's proven only through MRI, that nothing else is wrong. But the term foot sprain, I think, should be abandoned because this is what happens. Like, what the hell's a foot sprain?
Purposes only.
Yeah, there's no such thing. Like, you can't sprain your foot. Like, that's a bad problem. Like, a foot sprain is a Lisfranc injury. I mean, fundamentally, that's what it is.
Yeah.
You know, and I think if we as foot and ankle surgeons get rid of that term, stop using that term, and teach everybody not to use that term, it may trickle down to the ER doctors and the primary docs, because it's a misconception. So this case, you know, it's hard to see, but there's a subtle Lisfranc injury here. Lateral doesn't look that bad, but then we got a CT. He came in after a couple months, work comps, like, dude, my foot really hurts.
Yeah.
And then bam, now what do you do? So,
this is automatic fusion for me. It just, I mean, I know it sounds facetious, but it just, I mean, anything that goes through a joint, especially with that little bit of comminution right there, I'm just like, I don't want them coming back. I want to do it one and done. If you're gonna come back, it's just hardware removal. That's it.
It makes sense, man. So this is obviously it's a cuneiform fracture. If you look at the CT on the top right, you can see there's a subtle Lisfranc component to it, second TMT. But you know, that's the thing with this foot sprain. I think that's why I want to put this case out there. The foot sprain, you can't see it on X-ray. If somebody comes with a foot sprain, they're unable to weight bear or hard time weight bearing, check it. So I did it, or after the first. The problem with this case was, how do you fuse it with this goofy fracture pattern? So I chose a plantar plate because if you look at the CT scan, it's got a goofy comminuted cuneiform. So what fixation did you have available? And I did not want to go to the NC. So I did a plantar plate and a retrograde. I don't know why I used a headless screw. I will tell you, a retrograde headless screw, no. I think I always used a headed screw. I have no answer as to why I did that, but whatever, it works.
Right.
And I'll show his post-op. But how often do you fuse it with the plantar plate, or is this only for your revision? This is a weird case, so I had to use it. But what's your go-to for plantar plating for these Lisfranc injuries, if ever?
I'm trying to think the last time I actually did a plantar plate. I think it was just only for a lapidus with Arthrex, that plantar plate that they had back then. And I haven't touched it since for a long time. I remember when I was training with Fleming, he would try them out with, one-third tubular. He'll bend it and do all kinds of, cool shit with it to do a plantar plate, because innately it's supposed to be more stable, right? Because it's like, what you call it? It's opposite to the opening side, the gapping side.
It's on the tension side. So as they weight bear, it theoretically compresses, theoretically. But I think, it's not common for me. It's a pain to do, right? You put it over the anterior tib tendon. It's a bigger dissection. I think nobody likes doing it, but it's the value of it is in a case like this, like a medial plate would go right through the fracture. One dorsal, one plantar wouldn't compress this fracture at all.
What about like a dorsal plate? Wouldn't that be easier? Or
a dorsal plate?
Yeah,
it would be, but it's on the compression side, and it wouldn't give you that stability. And maybe it would have healed. Who the hell knows? But I think when in a case like this, it is something to consider. And it healed like a rock. This is 6 weeks out. I have a CT scan. He was a family of one of the radiologists at my hospital, but what ended up healing with the CT. But you can just see how nice and mechanically advantageous that is. And I will state that when you do a Lisfranc screw, ideally use a headed screw. This was a fusion, so it doesn't matter as much because it had such massive fixation around.
Right.
But that's my preference in general.
Yeah, same here. It just compresses better.
It's the best way. Here's a goofy case. 75-year-old diabetic, moderately obese, and has this disaster of an injury. Are you just saying this is Charcot, I'm out? But this is a true trauma. It's not.
It depends on his A1C, right? You know, if his A1C is out of whack, then yeah, potentially it's a Charcot. But do you know what the mechanism of injury is? Or
I got no. You know, it's funny. I never really. I mean, I either know it's like a massive car accident or fell and broke my foot.
Right. I mean but that will kind of determine. I mean, if he just fell and broke his foot, like he stumbled, like falling off the bed or something, that's different than, you know, a high energy trauma, right? So
this is a low energy trauma, not a car accident. You can even see the soft tissue, David.
Yeah,
like it's not that bad. So there's a low energy but horrific injuries. There's some neuropathic action going on here for sure.
Right. Yeah, I mean,
I'll give you the CT. It's just bad. What are you gonna say? So you have a Lisfranc kind of first TMT, but you got a shaft fracture of the second. That's not. I mean, the Lisfranc itself is fine. The medial column is unstable. Second TMT is fine. Third is popped over.
Yeah.
Fourth is not terrible. So
Yeah.
it's like a weird pattern.
I think the third one, there's a with a coronal plane fracture.
I think so, yes. And then the CT shows it right there. You can see that there's a coronal plane fracture.
Yeah.
So how would you treat this? And it's not fair. You don't have every image and all that kind of stuff. But I'm curious. It's a weird injury.
I mean, moderately obese, low energy trauma. If his A1C is good, like very good, then I would say I would just treat it like a normal trauma case. If his A1C is out of whack, then I'd probably treat it like a Charcot, which demands a lot more fixation and stuff like that. So, and I'm assuming he's sensate or non, or I don't know.
So moderately sensate. So I'll give you the whole story. So this guy was bad. So I did it percutaneous because he wasn't that healthy. So the third I did open. The first I just lined up and shot a bunch of wires in there. And I will show you, it was okay.
Pretty good job, yeah.
And in the end, his foot did collapse a little bit, but he didn't get an infection. That was my thought. So, you know, I really did not know what to do for this. I think when you see these bad diabetics,
or did he stay this way?
No, he collapsed a little bit more, but he never went to Charcot.
Oh.
And
yeah, a lot of these people fuse the subtalar joint, fuse the angle joint, even though it's like a separate issue, but it'll prevent that rear foot complex from rotating on the sagittal plane.
I didn't consider that.
Today's thinking. I mean, this just came out like recently too, so you know this was probably back then. So
I don't know what the right answer is. Like, this guy's not a great diabetic. He's moderately sensate. He's not totally neuropathic. So I thought, and I think for these diabetics, the key is to avoid a wound complication, get their foot somewhat stable. And if I had to go back and do a beaming, it's easy to do the beaming without infection, you know?
Yeah.
And because when you see an acute Lisfranc in a diabetic, the problem is you don't have time to get their A1C where it belongs. You don't have time to teach them. Like, you're kind of like stuck. You either watch it go to hell, and then it's too late, or we do these massive opens and we get these massive infections. So this is concept, and this whole podcast is not you can see these cases are weird. It's not to tell people what to do, like I have an answer or anything, but it's a thought that, you know, maybe these percutaneous fixation or minimally, you know, even though I did open on the third, to try to hold the foot somewhat where it is, and then come back and do something more salvageable later when you have control over the situation. Because I've seen it where people are like, well, I had to go do something, and they do this massive surgery, and then the wound goes to hell, and then you get an infection, you lose the leg. So sometimes a better part of valor is just to stabilize it.
Yeah.
Leave things and come back and fight another day. I don't think that's a bad idea.
Yeah, I agree with that.
There's another one now. 30-year-old, high energy, pregnant. This one was a tough one for me. I remember this case vividly. 30-year-old but pregnant. So the question is, what do you do now? Now, the
Chinese
question
finger
is,
trap.
how pregnant is pregnant, right? Like, does it matter to you when we see these cases, what trimester they're in? Do you care?
I mean, that is up to the mom for me. So we tell them, like, if we fix it, you got anesthesia, there might be an issue, with your kid or baby. But if you say, let's just go ahead and fix it, then um, then you sign a waiver and then we do it. Um, I'm kind of in that camp where the mom has to choose, and obviously we try to keep it as short, as simple as possible, so patients don't have to go through like such a long anesthesia time or whatever. But this one, I feel like you can do close reduction, just hang the foot using a Chinese finger trap type device. It should pop back in place. Then you can just either do a pop block to block off the leg and then just pin it and then just wait till later.
Dude, that's exactly my thought. So when you look at pregnancy, by no means am I OB-GYN or an intelligent human being, but whatever the mom gets, baby sees, right? And I got 4 kids, so I'm more sensitive to this than I used to be when I was single.
Right.
And so she was in her 3rd trimester. So baby's resistant, but any complication, disaster. The other issue was non-weight bearing. How do I ask a 3rd trimester patient to be non-weight bearing? It's a disaster.
Yeah.
So I thought, well, let me do exactly what you said. So I reduced it closed. We did a side, we just do SISAF blocks, short anesthetic, popped it and fired a bunch of perk screws, knowing that this was not going to work. But it stabilized it, put her in a boot, let her walk, because I'm going to fuse this later.
Correct. Yeah.
And that I did this in like 15 minutes. 15, 20 minutes. So the anesthesia to the baby was minimal. Mom did great. We had to put her on her side. And then you kind of temporize the situation. Is this going to become arthritic? 100%. That wasn't, but it's not always about, like, I think when I look at these things, sometimes when we talk to our trauma colleagues, they're like, I see this injury, I fix, therefore I did the right thing. And then they get some complication. I'm like, well, it's not just the fracture,
Right. Yeah.
And, I'm older now. And
Right.
so this is what happened at 6 weeks. It held, walking on it. And I went back and I did fuse it after the baby was born. A year and a half later, I ended up fusing the foot because it was still painful. But at least I got the patient through the period. So when we were thinking the same way, right? Even though it's a bad injury, dislocation, should get a fusion. It would take you at least, I don't care how fast you are, 45 minutes to an hour, maybe more, to fuse it, then demand non-weight bearing. And for a mother who's trying to deliver and get around, like, you can't ask them to do that.
Right.
So
you line it up for later. Yeah.
Line it up for later. And I think that's a good way to think about a lot of things. So this is the whole thing about Lisfranc. It's not fix or fuse. It's a lot of things.
Yep.
Here's another case. This is a 19-year-old collegiate level golfer. 1 through 5 injury. We've kind of had this case before. Would you do the same thing? 1, 2, 3 TMT fusion again, bro? So then I do the same thing. You have to ask. I did the same thing. I do a dorsolateral approach, really between the medial to the 3rd, and I'll fuse 2 and 3 first, which is weird because everybody says build from the medial column, but I don't. I actually lock in the middle column first. Retrograde Lisfranc screw. I'm fusing it, so I used a headless screw. It didn't matter at this point. And these wires here on my 3rd slide, that's the wires for the internal brace.
Ah, okay. I gotta try that sometime. I think that's I gotta try it sometime.
It's one of the few things that I talk about that I would say is really novel and actually is awesome.
Right.
And the person had cuboid fracture I fixed as well. And she went back to play collegiate golf. But I think, the whole fun thing about a Lisfranc is there's a million ways to deal with it, right?
Right.
And better part of valor, if you're ever in doubt, I agree with you, fuse it. and very subtle Lisfranc, I'm a fan of just doing what the closet fixation, small approach, fix it. And if they're, bad vascular path or 90 years old or 80 and the thing's dislocated, bad skin, just reduce it and fire screws across. So
Right.
what if they get a little arthritis? Like you don't always need to like slice and dice the whole foot open, get a solid fusion in a poor host or somebody who has other issues going on. Just line them up for the future. You can always fuse it. The mistake is to leave it alone.
Yeah. What do you do for your lateral column when they have like comminution or that type of stuff? I know it's hard. I don't know any right answer for that, but
if the lateral column is toasted, my truthful answer is I ignore it up front. Fuse the first, if it's like a disaster, right? 1 through 5, lateral columns hammered. I'll fuse 1, 2, 3. I'll do something to the cuboid the best I can to maintain length. And I just let the 4th and 5th, I'll pin them if I need to. And I'm not a big pinner, but I'll pin them if I need to, if they're so destroyed, and let them sort themselves out.
If it's comminuted, would you mini rail it or
no? Just leave it, because my philosophy is you're maintaining the length of the foot. So if I fuse 1, 2, and 3, I've adducted the foot and it's locked in. Sure. Lateral column gets distracted, and if they get arthritis, I do interposition arthroplasty with like an orthoflex patch after 6 months or a year.
Okay.
I'm not a rail guy. It's just not a thing that I do.
Gotcha. Okay.
But I mean, and it's just because I hate that stuff, It doesn't. I think it's probably maybe the right thing.
A lot of maintenance. Yeah.
A lot of maintenance, and I think once you've locked the medial column rigid, like where's the lateral column going to go? Cuboid is important to me. 1, 2, 3 TMT is really important to me. NC is obviously valuable. And then 4th, 5th TMT is kind of a garbage joint. I can always do interposition. Half the time they don't even complain.
Do you you're into position. I need to probably learn from you and watch you do one or something. Like mine never turn out like wonderful.
So I'll tell you what I do differently than how I was trained. I was trained to do like that ball type interposition, leave the bones between 4 and 5. All that I think is wrong because they just hurt. So I basically open up between 4 and 5, longitudinal incision, and then I will take used to take just a burr. Now I just take a power rasp, and I will take down about 7 to 8 millimeters of the entire 4th, 5th TMT joint, all the way down to the bottom, leaving some of the soft tissue on the bottom, but literally taking the entire thing like a block, like a rectangle.
Yeah.
There's nothing there. Then I'll take a suture tack because the fiber tacks don't work and just pure cancellous bone. I'll dunk it into the cuboid or the 4th and 5th, wherever I can shove it. I'll take an orthoflex patch and then pull a stitch through, take the stitch from the suture tack through the center of my patch, and then suture it down. And I'll take a freer and shove that sucker in and try to tie it down. And it slides the whole patch in, and then cut out the excess. And I have some pictures. We'll do one of these podcasts. We'll do instruction stuff. And that's worked much better than trying to do like individual 4 or 5 and making a donut and shoving it in or whatever the hell we were doing.
I was just doing graph jacket and trying to tie out the ends and then pass it to the bottom. And then I don't know. I probably need to debride more or something. I'll look at your instructions.
I think it is the debridement. You have to create a gap in there. And the only time I will do that if I fuse the middle column.
Yeah.
So the middle column has to be fused, because if you don't, it'll fall off and collapse.
Yeah, like too much motion going on. Yeah.
So if the middle column's fused, then you can go nuts on the lateral column. And I've been very happy with that for the expected, not perfect outcome,
Right.
Before we close, what about the intercuneiform variant? What are you doing for that? Are you doing anything unique? I mean, I make my incision. Are you just doing is there some screw configuration? Are you actually trying to prep and fuse the intercuneiform joint? What are you doing for those?
So believe it or not, I ORIF them with a screw, and they work out well.
It's hilarious. You fuse everything else.
Yeah.
But that one you fuse.
The irony, yeah.
That's too funny. So you put your screws across intercuneiform. Use 2, 1.
I do 1 or 2. It's usually 1. Sometimes if I don't feel like it's enough, I'll do 2. But most of the time it's 1, just intercuneiform medial all the way to lateral. And it's funny because nobody ever complains about that one, ever.
And is there a Lisfranc screw too, or no?
There's a Lisfranc screw too, yeah.
Lisfranc can you go all the way to lateral cuneiform to give you
Yeah.
some length.
But I'll fuse the Lisfrancs from the second met to the medial cuneiform. I will debride the joint.
You will in that case.
Yeah.
It's funny. Milap's not here,
Yeah.
but he's done a lot more of intercuneiform than I have because he sees so much trauma, and he has taught me to. I take the intercuneiform joint down now, drill the hell out of it, and I'll fuse it.
Well, now you can just take a Shannonburn and just shove it in there.
Yeah, just that's a nice way to do it too.
Right.
And then make sure I pull that sucker to length to get that NC. I always look at the NC joint when I do an intercuneiform variant. Make sure it's popped open, and then I'll lock it. And I do like I don't always go to lateral cuneiform. I like that concept because the middle cuneiform is so tiny, man.
Yeah,
I like that concept a lot.
If you shoot it in an angle, because it's like 3 centimeters thick, right, and the depth. If you shoot at an angle, you actually have it's actually a lot bigger than you think. It's just on the
bottom you get squat. You've got to aim high.
Right, you got to kind of aim at an angle.
Yeah, I think you're right. But I like going the lateral cuneiform. That's a nice way to get more fixation. And then I'll disimpact the NC sometimes. Put a little bone graft behind that cartilage damage, and they've done okay. You know, like it's not like they suddenly need. I was curious if you're gonna do like an NC fusion acutely. I have not.
No, never. I don't think I ever. I always try to reconstruct the navicula if it's like a navicular fracture, but I try to reconstruct it. But I don't. So your incision is pretty long then.
Oh yeah, for an NC one, I make a big incision.
For even intercuneiform, you'll go past that far out.
For an NC, because I like to look at the NC joint. I think they're bad actors, and maybe I'm wrong.
I probably need to do that more often because I don't. I just kind of I base off the CT, like where the fracture is. That's where I go. But
probably fine too. You know, I for me, it's very hard for me to judge the NC joint radiographically. Do I have enough disimpaction? I will tell you, in my 20 years, I've probably done like 10 of those. I don't see that many. I'm not going to sit here and tell you I've seen 200. I've done more weirdly weird cases than I have navicular cuneiform variants, you know? So I don't know, but for that particular case, I do think for me looking at it makes sense.
So what's the indicator of, let's say they have a TMT stuff and then you go all the way to the NC to kind of check it out? Like you dissect all the way up there.
What's my indicator, you mean? Like,
yeah. So just a regular TMT fracture, you said you would dissect all the way up to
no. Only if it's a true navicular cuneiform variant.
Oh, okay. I understand.
It goes right through the cuneiform and the NC is blasted.
Yeah.
That's the only ones I go the NC. These other ones I just do this stuff. Not a small incision, but
right.
Few centimeters up.
Right.
As you know, I used to not care about incision size, and for the love of God, I still don't. I do MIS out of principle, not out of cosmesis. And I think if you're going to go open, go open. Look at what you're doing, see it, do it right. Minimize damage, soft tissue damage as you need to. And MIS is just a totally different philosophy, obviously.
Right.
But like making a 4 centimeter incision or a 6 centimeter incision, I could care less at this point because I've been around long enough. What I've noticed is when I make a 4 centimeter incision that needed a 5 or 6, I'm crushing on the skin, pulling hard. And, I like window retraction, so I can minimize it. But if you're struggling, just make it a little longer. The soft tissue nerves, they do fine. They do better, actually, because you're not trashing the skin,
Right.
Cool. Perfect. So hopefully this was fun for everyone. It's like not your straightforward fusion versus RIF conversation. And then I think, what we'll do some crazy midfoot revision cases next time, which will bounce off of the Lisfranc. So thank you everybody for joining. Thanks, David. And hopefully generate some conversation.
Yep.